The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.
Welcome to JCO's Cancer Stories, The Art of Oncology, brought to you by the ASCO Podcast Network, a collection of 9 programs covering a range of educational and scientific content and offering enriching insight into the role of cancer care. You can find all of the shows, including this one, at podcast.asco.org. Welcome to Cancer Stories. I'm Dr. Daniel Hayes. I'm a medical oncologist and a translational researcher at the University of Michigan Rogel Cancer Center, and I've also been privileged to be the past president of ASCO. I'll be your host for a series of podcast interviews with the founders of our field, have been and will continue to be over the next several months. In this series of podcasts, I'm hoping to bring the appreciation of the courage and the vision and the really scientific background among the leaders who founded our field of clinical cancer care over the last 70 years. I hope that by understanding the background of how we got to what we now consider normal in oncology, we can all work together towards a better future for our patients and their families during and after cancer treatment. Today, my guests are Dr. Larry Einhorn, who first demonstrated the cure of testicular cancer with cisplatin. And we have a special guest, Mr. John Cleland, who, as far as I know, was the first man to be cured of this cancer with cisplatin in the world. Dr. Einhorn is currently a distinguished professor of medicine on the faculty of the section of hematology oncology at Indiana University School of Medicine. Mr. Cleland is now retired after a distinguished career as a high school teacher and track and field coach in Indiana. This interview is really particularly poignant for me. I knew John Cleland socially before I'd ever heard of Larry Einhorn because our respective wives worked together while I was in med school as I began my clinical training. I then had the enormous privilege of being assigned to the oncology ward at the University Hospital for one of my rotations in internal medicine during my 3rd year in medical school in 1977, and Dr. Einhorn was the attending. And frankly, for me, the rest is history. I had no chance. I had to become an oncologist. Dr. Einhorn received his undergraduate degree at Indiana University, went to medical school at the University of Iowa. He then returned to Indiana for his residency and fellowship, but he spent an oncology fellowship year at MD Anderson in Houston, after which he then returned back to IU in 1973 and has remained there ever since. He has won nearly every award and honor available in clinical research, and I'm not going to try to name them all, but most importantly to me, as with many people in this podcast series, he has served as president of ASCO, in his case in the year 2000 and 2001. Dr. Einhorn and John, welcome to our program.
Thank you.
Dr. Einhorn, I'll start with you. Obviously, your greatest contribution is the cure for testicular cancer, which is pretty good. Can you kind of walk us through the history? How did you get involved with cisplatin? How did you derive the 3-drug regimen? What were the early obstacles, especially with your returning back to Indiana? Can you kind of just walk us through that history?
Certainly. So as you mentioned, I did a 1-year fellowship in oncology at MD Anderson before returning to the faculty in 1973 at Indiana University. And in that time period, which was 46 years ago, the thought was that you might be able to cure adult leukemia like was cured with childhood leukemia from the wonderful studies from St. Jude's, and that the studies that were ongoing in lymphomas and other hematological malignancies were very promising. But it was felt that you really don't want to do too much toxicity in a solid tumor where you're getting a 1-log kill before you get progressive disease. And there was a clear pervasive atmosphere of pessimism of what can be done with solid tumors in general. So when I joined the faculty in 1973, I was the only oncologist. We had 2 hematologists that were there in our small faculty, which went from 2 to 3. And I wanted to be involved with both liquid tumors as well as solid tumors. But I wanted to be involved with solid tumors that were chemosensitive. And even back in the early 1970s, testicular cancer was responsive to older drugs like actinomycin D and later with a two-drug combination of vinblastine plus bleomycin. And there were a small number of not just remissions, but cures. And that was one of the few solid tumors that actually had a modest cure rate back at that time. And then the platinum story came around. And this is a podcast of itself with the wonderful work of a biophysicist at Michigan State, Dr. Barnett Rosenberg, who first discovered that platinum could be the first heavy metal ever to be looked at as an anti-neoplastic agent. And when platinum entered first in human clinical trials in 1972 and 1973, it was felt at an NCI-sponsored phase 1 working group that I attended that this drug was producing minimal benefit and tremendous toxicity, especially horrendous nausea and vomiting. And the drug was pretty close to being discarded as an interesting novel mechanism of action, but not a drug that really had much of a future. But what changed the history of platinum and changed the history of testis cancer was the fact that among the phase 1 patients who were treated with platinum, which included melanoma, lung cancer, colon cancer, breast cancer, the usual type of patients that entered phase 1 studies back in those older days, were 11 patients that had testicular cancer who had failed actinomycin D, failed vinblastine plus bleomycin, and so they received single agent platinum. And when we, even today...
Actually, Dr. Einhorn, where were those studies done?
That was done at Roswell Park, actually, phase 1 study. And Roswell Park, and this was an era, by the way, that there were only 4 NCI cancer centers in the United States: Roswell Park, MD Anderson, Memorial Sloan Kettering, and, of course, the NCI. So Roswell Park did a broad-based phase 1 study. Jim Holland was there at that time. He has unfortunately subsequently passed away. He was one of the real pioneers and also a past ASCO president. So among the patients in that phase 1 study were 11 patients with testis cancer, and there were 3 complete remissions and 2 partial remissions. And even in 2019, if we saw that with a phase 1 novel agent, there would be a tremendous amount of enthusiasm generated. We also looked at some of the preclinical work with platinum, and it is a drug that can cause testicular atrophy. In my youthful ignorance, I didn't realize that there are many drugs that cause testicular atrophy. So with that as a background, in 1974, and I was on the faculty for 1 year at that time, we wrote a protocol to simply add platinum, a novel experimental drug, and added it to the established two-drug regimen that I learned about when I was at MD Anderson, namely vinblastine plus bleomycin. And the principles of combination chemotherapy aren't complicated. You want each drug to have single-agent activity, different mechanism of cytotoxicity, different toxicity, and platinum is a non-myelosuppressive drug, which can be given in full dosage with vinblastine as a myelosuppressive drug, and evidence of synergy. And one of the unique characteristics of platinum is it is synergistic across a panoply of cytolytic agents. So we started the study in late summer of 1974 as a phase 2 study. And so we treated 47 patients when we first presented this data at the American Urological Association and later ASCO. And I would be the first to admit that I was as startled as anyone that we were able to literally have a 1 logarithmic increase in the cure rate, because most progress in oncology is going from a 5% to a 10% to a 15% long-term survival rate. But all of a sudden, with this 3-drug combination, 60% of these patients were not only complete remission, but durable complete remission and cures. There was a lot of toxicity with platinum, and over the years we learned, as science tends to learn when a drug is active, to mitigate the side effects as far as nephrotoxicity and nausea and vomiting. And we made modifications to the treatment regimens as the years went by, as you know, with changing the dosages of vinblastine, lowering the duration of maintenance therapy and eliminating maintenance therapy, reducing the number of courses of platinum, substituting etoposide for vinblastine to where it's now the standard bleomycin etoposide platinum, or BEP. And I would make a final comment in my long career that this was a very exciting time in 1974. There were several chemotherapy drugs that were experimental drugs, such as doxorubicin, and even the nitrosoureas, the first drugs that have penetration into the blood-brain barrier. But the era of chemotherapy is gone, and appropriately so. And science and medicine has moved forward. And now we look at molecular targeted agents and immune checkpoint inhibitors and immuno-oncology. And that's what is exciting, so much more exciting about the field in 2019 than it was in 1974. But nevertheless, platinum has had legs. In 2019, it is still first-line therapy in 12 different types of malignancies. Of course, testis cancer being the poster child for a curable cancer. And I often mention that just as platinum has cured thousands, tens of thousands, hundreds of thousands of young men with cancer, testicular cancer saved platinum, because if it weren't for those early studies showing activity of platinum, I think I can say without fear of contradiction that the drug wouldn't be around right now because of its tremendous toxicity in the early phase 1 studies.
Yeah, Larry, let me ask you about that, because in the early 1970s, I wasn't around, but you didn't have antiemetics, you didn't have growth factors, you didn't really understand the renal toxicity. Just briefly, how did you get around those? How did you get people? I'm going to ask John the same question.
Well, John is a recipient of our ignorance in that era. So taking it one at a time, platinum is a heavy metal, and we were somewhat slow in realizing that other heavy metals like mercury can cause acute tubular necrosis. And so when patients were getting platinum, as is true in those days, they would often just get IV push platinum. And so we learned that in order to prevent acute tubular necrosis, we needed to make sure that patients were well hydrated with IV saline solution before they start chemotherapy. We then give the intravenous platinum and then follow that with intravenous saline hydration so that the drug doesn't accumulate in the proximal tubulars. We force a diuresis, and we never needed mannitol. And some people back then, in fact, perhaps even now, are doing the silly thing of mannitol diuresis, which is totally unnecessary. And so back in the early days, before we had antiemetics, everyone had to be treated as an inpatient because we had to give 24-hour continuous hydration because of the prerenal azotemia from severe nausea and vomiting and dehydration that would happen. Of course, today is all done as an outpatient with 3 or 4 hours of hydration. As far as nausea and vomiting is concerned, one of our first studies we published in the New England Journal of Medicine was a cannabinoid derivative from Eli Lilly called nabilone. And so nabilone didn't produce a marijuana type of high. It didn't cause euphoria. It caused some dysphoria and had a variety of side effects, but it lowered the incidence of nausea and vomiting. But what revolutionized chemotherapy-induced nausea and vomiting, and ASCO recognizes as one of the 5 leading advances in the past 50 years, was the discovery of the first 5-HT3 receptor antagonists. And this was a rational, selective pharmaceutical development. And this truly changed the face of how we give chemotherapy with drugs like platinum. Instead of having an average of 10 to 12 emetic episodes on day 1 of platinum, today with appropriate antiemetics, the median number of emetic episodes is 0. People still get nausea, people still get occasional vomiting, but everything is done as an outpatient now, and it's done as an outpatient because of the discovery by others of what is the mechanism with platinum, which is not a gastrointestinal mechanism, but affects the emetic center in the medulla oblongata and the chemoreceptor trigger zone, and finding that patients get drugs like platinum, they get high levels of 5-HT3, and developing a selective 5-HT3 receptor antagonist changed the field completely. And of course, now we also add dexamethasone and a neurokinase 1 antagonist, a prepitant or fosaprepitant, and we also have olanzapine as far as the nausea issue, and olanzapine is probably the best drug for nausea. So patients today have no concept of what patients like John went through when we had no knowledge about any of this whatsoever, and we were looking at things kind of naively by 2019 standards.
I don't think I'm making this up. I recall as a medical student walking down the inpatient unit at University Hospital and thinking, this smells just like my fraternity house.
But without the fun involved.
Yeah, and I get a kick now out of so-called medical marijuana, but didn't you talk the administration into looking the other way for a while so that these guys could do that?
Sort of. So what had happened with Nabilone, it had to be under lock and key as if it were gold at Fort Knox. When we had an audit by the FDA and we had, I don't know how many, I think 60 or 70 patients on Nabilone, and we had to make sure we had every consent form and every safety guard and everything. Here we're using these incredibly toxic chemotherapy drugs and there was no regulation at all. And here we're using a pill to lessen nausea and vomiting, and it was just the hoops you had to jump through were tremendous.
When did you start realizing you had something big? Was it, after 2 or 3 patients or later?
Well, again, when you're young and dumb, it's easy because you treat someone like John and you get the first chest x-ray 3 weeks later and things are gone and with pulmonary metastases, and you naively think not only this cool, but gee, that's great, it's not going to come back again. But we know even 40 years later that most epithelial malignancies that we get nice remissions with, the disease does come back again. So we had initial enthusiasm that platinum velbam bleomycin was a very active but very toxic regimen, and we had the hope that this might be durable remission. And Dan, I actually first presented data with testis cancer, not at ASCO, but with the annual American Urological Association meeting, and that was 99% urologists there. And so we had 20 patients that we had treated. And then that following year, I submitted an abstract to ASCO, and back then, it wasn't done online. We would send a paper abstract with a self-addressed postcard that they would send back to us, whether it was accepted or not. And so when I sent in the abstract, I get the postcard back saying that it was accepted as a plenary session paper, and I had no idea what plenary session even meant. And it's true. And so and we get this postcard back in January for this June meeting, and all of a sudden my naivety went away, and I thought, what if I make a fool of myself? And I had this initial abstract with these complete remissions, and by the time June rolls around, every one of them would have relapsed, which I was starting to learn happens in other tumors like small cell lung cancer that are chemosensitive disease. But fortunately, at the time of presentation, everyone was still disease-free, and of course, everyone, for the most part, remained disease-free. So we had the first glimpse of activity with the first few patients, but it really wasn't until patients were out at a year that we really had the realization that these were not temporary remissions, but these were durable, and as it turned out, permanent remissions and cures.
I wasn't there, but I understand that after you reported that it looked like you had changed the ratio of cure to not cure from 10%, 90% to 90%, 10%, that people in the audience, that you got a standing ovation at the end of your presentation.
Yeah, it was very, very heartwarming. It's literally the walk on the moon type of things is the things that you do once in your career, that you never forget about. And I had the opportunity to do that at not one of those 4 NCI cancer centers, but Little Indiana University with our faculty of 3, and we had 1 oncology nurse at that time, Becky Furness. We had no data managers. We had no compliance office or anything else. It were different times back in the 1970s.
I'd like now to turn briefly to your relationship with John Cleland. John, can you give us a brief history of your cancer treatment before you and Dr. Einhorn decided to go with the cisplatin?
I was a student at Purdue University the fall of 1973 when I discovered I had a lump on my left testicle. And I went to a local urologist, and he examined me on a Tuesday afternoon in the middle of November and told me he wanted me in the hospital the following morning. And following day after that, they performed surgery, and I was diagnosed with testicular cancer. That was in November 15th, 1973. On the 29th of November, then, I had a retroperitoneal node dissection at Dennis Value Cancer Center by Dr. John Donahue. And then on December 3rd, 1973, on a Monday morning, Larry Einhorn walked into my hospital room, and that was my first introduction to Dr. Einhorn. He talked to me a little bit and said we were going to put me on a 5-day course of a drug called mithromycin. And we took mithromycin for 5 days, and then a couple days after that, I was released from the hospital. So that was in the 1st of December of 1973. Middle of February of 74, I returned for the IU Med Center just for a routine checkup, and I was diagnosed there again with testicular cancer that returned. And Dr. Einhorn began putting me on a 3-drug regimen, adriamycin, bleomycin, and oncovin, and I was on that until about July of 74. Then I was on actinomycin D for a couple of months, and then we ultimately started in on the cisplatin in early October of 74.
Now you have to tell us a story that you actually had to tell Dr. Einhorn about cisplatin because of a radio show you listened to.
Well, by the middle of the summer, I'd been pretty beat up after all the chemotherapy and the nausea and everything, and I didn't really have a job, or I couldn't do a job or anything. So most of the time I just lay on the couch in our apartment and listen to the radio or watch TV. And one day I really liked Paul Harvey, and he came on the radio every day at noon there in Lafayette, Indiana. And one day he begins talking about researchers at Michigan State University have maybe come up with a cure for cancer. So I, began, listening much closer, and they talked about this chemotherapy called cisplatin. So I just made a mental note to myself, well, and the next time I go see Dr. Einhorn, I'm going to ask him about this. Well, a couple weeks later, I'm down in IU, and he's palpating me and listening to my chest and all this type of thing, and I began asking him about that. And he said, John, just don't get too excited about that. We've heard of these cancer cures before. Probably nothing important has happened here. No, don't worry about it, And then 2 or 3 months later, I'm taking it. So that was my introduction, Dan, to cisplatin.
Well, I can't tell you.
Some of those Purdue graduates are pretty smart every now and then.
We get lucky, like a blind squirrel.
I was going to say, I can't tell you how many, probably 100, 200 patients who have told me things like this, and I've said exactly what Dr. Einhorn said to them. Yeah. I wonder how many cures I've missed. Okay, and the second story I want you to tell us, John, is about your readmission to the hospital after your first cycle of chemotherapy.
Yeah, I started the cisplatin on October 7th of 1974, and I had 5 doses in the hospital, and then I was released. That was on October 7th. October 20th rolls around, which was a Sunday, and I was violently ill. I had a fever of over 100 for almost 104.5, and I was just completely almost derelict. My wife and a couple of friends, we contacted Becky Furness, my oncology nurse, and I guess she called Dr. Einhorn, and he'd said, well, come on down and check in through the emergency room at IU. So that's what we did. And we got there late at night, 9:30, 10 o'clock at night, something like that. And they always, if I went through the emergency room, they always took a chest x-ray, which they did. And then in the hospital overnight, and middle of the next morning, I see Dr. Einhorn and Becky getting off the elevator. My room was kind of in a corner. I could see part of the lobby out there in the elevator and the nurse's station, and I could see them kind of go past the nurse's station, and I could just tell that something was up. Somebody had good news, let's put it that way, just by their body language and the way they looked at each other and talked and walked, and they kept coming closer and closer and closer to my room, and finally they walked in. And Dr. Einhorn says, John, your chest x-rays are clear. That's really good news. And, I kind of interpreted that as, hey, I'm sure, And ultimately, I guess I was, because from that chest X-ray the night before, my chest film was, the week before, my chest film was just riddled like Swiss cheese. And this film was totally clear.
You probably don't know this, but I've seen your chest X-rays, which is probably illegal now. But
well, we probably did a lot of illegal things back then.
Yeah.
So.
That's when the scales fell from my eyes, and I said, I'm going to be an oncologist. This is unbelievable. But, I think to emphasize, it wasn't clear you were going to survive that weekend. If you survived, you would be cured. But that goes back to how toxic this drug was at the start.
Right. It was not a lot of fun. I know that.
Yeah. Well, I want to get back, Larry, to you for a moment, because there were two people in your lives who were really essential to the story. One, of course, was Dr. Donahue, with whom you published the, I think, seminal and classic paper in the Annals of Internal Medicine. You want to say a few words about John? And the other is I'd love you to talk a little bit about Steve Williams. Steve was a fellow when I was a med student, and I used to tease him. He's the only guy I ever knew who went from being a fellow to cancer center director, I think, in 1 year. I'm making that up, but he kept saying, Einhorn won't put me on faculty because he doesn't have any other fellows. So.
Yeah, sure. So when I joined the faculty in 1973, in July of 1973, as I mentioned, I was the first oncologist. There were two hematologists there. And John Donahue is a true gentleman, one of the world leaders in urological oncology and urological transplant with kidney transplant and many other fields. His ability to surgically cure patients with extensive retroperitoneal disease was known worldwide. And because of who John was and the fact that there were very few oncologists in the state of Indiana treating solid tumors, when he would see patients who would relapse after a retroperitoneal lymph node dissection, he would give chemotherapy himself, usually with actinomycin D, which, by the way, causes almost as much nausea and vomiting as platinum did. And when I first got there, I knew John by reputation, but not by his interpersonal relationships with others. And with some fear and trepidation, I walked into his office because I told him I wanted to start looking at clinical trials in testis cancer. And I thought we might have a turf battle because he was treating patients with chemotherapy himself. And he just welcomed me with open arms, and he was so enthusiastic about finally having a partner and someone to collaborate with. And we had a wonderful 30-plus years of collaboration with many important discoveries that John made equally as I did. And it's unfortunately, after John retired, he subsequently died when he was in Florida. And it's a similar sad story with Steve Williams. So Steve Williams was in my third fellowship class, which means we had one fellow a year. Steve was great, very humble, from Bedford, Indiana. And his father was a newspaper reporter from the small town newspaper. And Steve was the eternal optimist. And to show you what an eternal optimist he was, when the Indianapolis Colts would lose 14 games in a row, he always knew they were going to win the next game. And that's Steve. And John Cleland talking about Paul Harvey, Steve would have believed that platinum was going to be the cure too, He was just a very positive person. And Steve was very gifted. He has a great relationship with patients. And there's not a person, doctor, nurse, or patient who has ever said anything unkind about Steve. He's one of the kindest people that we ever had the privilege of knowing. And Steve was very much involved with our testicular cancer research studies and many other pivotal studies as well. We decided to be a NCI Cancer Center, which is an enormous amount of work. And by then we had about 10 faculty members in hematology oncology, and no one wanted to do it. And so we went up to poor Steve and said, boy, Steve, this would be a great career move for you, without telling him how much work is involved. We are a cancer center today because Steve Williams made us a cancer center. everything that goes along with that. And before leaving, and unfortunately, we're talking about John being cured with fourth-line therapy with platinum combination chemotherapy, whereas if John had had that disease diagnosed a year earlier, quite honestly, John, you wouldn't be alive right now. And it's sort of the opposite for Steve Williams. He eventually developed metastatic melanoma before any of the marvels with immunotherapy or even the BRAF inhibitors were around, and he eventually died from these diseases that he fought so hard to palliate and prolong survival and cure with metastatic melanoma.
And now there's a 30% cure rate.
30% 5-year survival and continuous 5-year survival, even with single-agent PD-L1 inhibitors. And I want to make a final comment about John. And if this were 2019 rather than 1974, and you're looking at a patient who's been through mithramycin, which was used by me as adjuvant therapy briefly for adenocarcinoma, which is what John has, and then going through actinomycin D and all the toxicity with that drug, and then gone through an adriamycin combination chemotherapy, and looking at fourth-line therapy. So when we started platinum combination chemotherapy and John is fourth-line therapy, yes, his chest X-ray looked like Swiss cheese, as he mentioned, but he was pretty much asymptomatic. And the courage and fortitude that it takes to go through treatment like this, because we knew what the side effects were with platinum. It had been around for about 8 months, and we knew about all the horrendous side effects of the drug. We had no idea whether this would produce as fourth-line therapy any prolongation of survival or any meaningful quality of life. And to go through this therapy without any idea of whether it's going to help you, but to do it with truly altruistic motives and knowing that maybe this will help other patients in the future is really noble and admirable. And this is why John, over the decades, has been such a role model for clinical trials and for the cancer patient population.
And I want to follow up, John, briefly. Tell us about your history since then, your family, your athletics, your career. I mean, I think it's inspirational, frankly.
Well, I worked in the animal science industry for 5 years following my cure, and I decided finally I needed to give something back a little more to society than what I was actually doing. So I knew I wasn't smart enough to be a medical doctor. Male nursing wasn't exactly in vogue at that time, which might have been actually a pretty good job for me. Because I thought, well, I could be a teacher. I can teach life sciences because my background is pretty much life sciences in agriculture. So I did. I turned to teaching biology for 31 years and did a lot of coaching at track and cross country. And my wife and I have 3 kids. I married my college sweetheart even before I had testicular cancer, and I owe her just about everything in life. She hung in there with me when times were really dark, and so we've got 3 kids, and I've had a great job and great career and great friends. I want to emphasize
you've had 3 children since your treatment. I also want to emphasize I know you've run 1 or 2 marathons since your treatment?
Actually, Dan, I ran 4 marathons.
There you go, 4 marathons since your treatment.
4 full marathons, yes, sir. Yeah.
And I believe that your baseline creatinine is something like twice normal. And Larry, you probably know this better than I do. But again, you've been inspirational to all of us. So. Well,
thank you. Thank you, Dan. I'll tell you this. Every day I live is a blessing. I should have probably died 44, 45 years ago. I could drop dead at the end of this telephone conversation and have no regrets in life whatsoever. So.
Well, John, you keep thinking that maybe one day you're living long enough to see Purdue win the NCAA, but I wouldn't count on it.
Well, I was going to make a point. It must pain him thoroughly to thank 2 guys from Indiana and also be appreciative of Michigan State. For a guy from Purdue, that must really be painful.
Well, yeah, the testicular cure is basically Big Ten centered with Michigan State coming up with cisplatin and Dr. Einhorn being on the IU faculty, but it took a Purdue Boilermaker to be tough enough to handle all that therapy to begin with,
That's true. Okay, we're running out of time. I'm going to need to bring this to an end. I want to thank both of you. Again, both of you are inspirational. John, for all the things we've talked about, and Dr. Einhorn, for so many of us who've gone into the field that you've trained, and even the ones you've never touched directly, you've touched hundreds of thousands of oncologists around the world indirectly. So thanks for all your contributions and what you've done. And thank you both for being on this podcast. I hope it opens up more inspiration for other young investigators and other young oncologists who don't really realize how we got where we are. So with that, we'll end this, and thanks a lot, and hope you have a nice weekend.
Okay, thank you, everyone. Have a good rest of the week. Bye-bye.
Until next time, thank you for listening to this JCO's Cancer Stories, The Art of Oncology podcast. If you enjoyed what you heard today, don't forget to give us a rating or review on Apple Podcasts or wherever you listen. While you're there, be sure to subscribe so you never miss an episode. JCO's Cancer Stories, The Art of Oncology podcast is just one of ASCO's many podcasts. You can find all the shows at podcast.asco.org.